My name is Beth Boudreau. I know most of you, and I'm very grateful that you're here. Hope everybody is well and back in the office. We have some exciting information to share with you today on our 2.2 or 2.2, software updates. And I think you're going to be really excited about this. So I'm not going to take a lot of time. I'm going to turn this over to Jason Pardo. Most of you know Jason as well. He's the VP of Sales and Marketing at Navident. So Jason, I'll turn it over to you.
Thank you very much, Beth, and thank you for organizing all of these webinars over the past 3 months to keep us all up to date. As Beth said, I'm Jason Pardo. I'm VP Sales and Marketing for Claronav, makers of Navident. I do know most of you personally, and can say that it is wonderful to at least virtually be in your presence for part of this webinar, sharing all this exciting Navident advancements for our 2.2 update. It is a true pleasure to be doing this ride along on the webinar with my dear friend Silvia Rosa. I met Silvia just over 15 years ago in the first year of my dental career, and I was immediately impressed by how thoughtful and passionate she was about her profession. As I got to know her even more, I was even more impressed by what a caring and compassionate human being she was. So as the years have gone by, I've seen how she and her husband and business partner Manny, also a lovely person in his own right, they've built a thriving specialty practice and practices by combining their professional passion and personal compassion for their patients, their staff, and everyone lucky enough to be in their orbit. Given all of that, it's no surprise probably that upon being hired by Claronav in 2015, Silvia was one of the first people I spoke with. She was very interested about the product, potentially a little dubious, as some of you probably were, and as always, very inquisitive. She had a lot of questions. They were good questions, and then there were some more questions, and then there were a few more questions, and then after about 3 years, I had answered enough of those questions to her satisfaction that she and Manny purchased their first Navident unit, and she jumped into doing cases with both feet. Since that time, she's done more navigated dental cases than all but a handful of people on the planet, and has been instrumental in helping us to refine and refocus our efforts to better serve her profession and her patients, and your profession and your patients. So she's always available to test new tools, discuss future applications, and share her best practices. And she is without a doubt one of the best presenters I have ever had the pleasure of seeing online or in person. So I'll be taking a back seat because of that. I'll be taking a back seat and watching the show along with most of you for the next hour or so. I will be fielding some of your questions if I can via the chat room. So feel free to type those in. If possible, I'll also interject into the conversation and fuse those questions into Silvia's presentation when appropriate. If I or we don't get to your questions live in writing or verbally, we'll take the time to go over them and answer them together in the Q&A. So that's all for me. On with the show, and Dr. Rosa, please proceed. Thank you.
Thank you, Jason, for your words are always very kind. It is a pleasure and an honor for me to be sharing my experience and presenting to a group of colleagues who, like me, see navigation as a great tool to improve not only our patients' experience, but the outcomes. And before we start, I just wish that everyone has returned to your workplace safely and highly motivated. We know that these trying times will definitely pass, and in the meantime, we need to continue enjoying and loving what we like to do. Many of you have seen some of my presentations and know how passionate and how excited I get with navigation. My take-home message for both part 1 and part 2 is related to routines. So my advice is making navigation a routine will be always the key to success. It will be always the key to becoming familiar with the technology. So how do we become familiar? How do we make navigation a routine? We do so by actually doing every single case with navigation and by every single one of our team members. And then we'll become very efficient as we become familiar with the technology. I love quotes. This one in particular, there is no elevator to success. We have to take the stairs by Zig Ziglar. And this is so true. And this applies to every technique and every technology that we incorporate, that we adopt in our practices. We have to definitely take the proper steps to dedicate the time to learn techniques and technologies. We have to create protocols. And we have, most importantly, we have to involve and empower our team members. So today, I'd like to share with you the features of the Navident software 2.2. And in addition, I'd like to share with you how is the navigation workflow in our practice for every single case. So I will start with the navigation workflow, and we will divide this into 4 segments. We'll start with the diagnostics. I will jump into the surgical suite, as we will spend more time with the planning and the surgery through the case presentations. So regarding the diagnostics, in every case that we do, we're going to acquire a CBCT, an optical scan, photographs, and when in need, a facial scan. So let's start with the CBCT. I always, again, and I will talk a lot about the team because we definitely involve them in every step of the way. We teach them the technologies as basically we know them ourselves. And one of the things that we always talk about is not just on the acquisition of any images, but on how to evaluate these images. A good trained team member and lab technician should be able to reject a poorly acquired diagnostic image. And that is really important because we know this is a trickle effect. A poor acquired image is going to lead to poor diagnosis, to poor planning, and therefore to poor execution of your procedure. So with CBCTs, the most common pretty much acquisition problems that we have are typically double images, cutout regions, or the field of view, or related to the field of view. So let's review a little bit of all of them. So when it comes down to double images, we know that it is either because the machine touched the patient as he's rotating through them, or because the patient moved. So one of the things that we do is we do a scout image in preparation to the real image. And that way the patient gets used to or understands what's going to happen around them. Regarding the cutoff regions, the most common cutoff region is the maxilla. And that happens when we have a patient who is very tall or is dolichocephalous. So the solution for that is you want to seat your patient and make sure that the plane of occlusion is parallel to the floor. And that way you actually are able to see both in completion the maxilla and mandible. Another cutoff region that is very common is the anterior region. And that happens when the patient is too forward and rested on the chin rest of the machine. So again, doing a scout image will prevent all these problems from occurring. When it comes down to the field of view, it is very important, especially for navigation, that we acquire enough landmarks for registration on these images. So in our office, we have, since I'm sharing what we do here, we have a Pmma Pro Max, and what we did when we acquired the technology is we did pre-settings. So if I'm doing a single implant or multiple or a full arch, I will again select amongst them. So for a tooth, we always will stick with a 4x5 centimeter image, which is a small field of view. And that is one that is most preferred also by endodontists. Now the problem with such a small field of view is that we may run into not having enough landmarks for registration. However, Navident already has created a solution with its hardware, and I will be presenting a case where you can see how we can solve this problem. For teeth, when we are doing multiple teeth, let's say an implant supported bridge, we can go up into the teeth selection, which will be a field of view that ranges from 8x8, 8x6, or we can select 10x10. And if we're looking at a full arch, we definitely need to incorporate enough anatomical landmarks for registration. So we will select a 16x10, 16x16, or 20x20 field of view. When it comes down to the optical scan, it is also very important that the team members understand the accuracy of these images and and how to reject one when it's not well taken. The most common problem is the pacing and the retraction. So with the pacing, we need to make sure that they're not scanning the patient too fast, because they will most likely than not omit the height of contours, the contact points. And the most commonly missed region is the bicuspid region and the canines. So again, good pacing will allow them to take a very accurate intraoral surface scan. Now retraction, it's very important. And with retraction, some team members are used to just using the scanner and their hand. We have in the office, we have the ScanMate, which is a radiopaque retractor developed by Armor Dental by Cherie Lepensk, which is a great tool to retract when you're doing the optical scan, and it is non-reflective. Now, as far as photos, we take extraoral photographs, intraoral photographs, and then in the full arch cases, we can obtain a facial scan, and that will help the laboratory create the full planning. Nowadays, it's very easy to take a facial scan. If you acquire an iPad for your office and upload the app for Velos 3D, you can take a very good facial scan that will be very useful for your laboratory. Now, what about the communication with the laboratory? We have a template that I'd like to share with you. I am going to share with Beth and Jason so they can share with all of you. This is the template that we have in our emails. Our team members who are in charge of communicating with the laboratory will customize this email. The most important things here that I have highlighted is assuring that the laboratory mirrors the teeth and the jaw structure in the edentulous spaces. And why is that? Because laboratories, which I have seen for years, they tend to create compensatory wax-ups, either analogs or virtuals. And the problem with that is we don't have proper diagnostics. We don't have enough information to tell us with the compensatory virtual plans if we have a deficiency of the bone or the soft tissue. So again, this is a critical point, and I will tell you still until this day, I still have to make phone calls to the lab or emails making sure that they change their virtual plans for that reason. Second thing that I have highlighted here is the printing of a Pmma provisional. I tend to, in the majority of cases, my goal is to place either a custom healing abutment, a tissue former, or a provisional. And that is when the insertion torque allows for it. So it is very easy. They print the corresponding digital wax-up in Pmma, and I have it available chairside, which is very easy to adjust. So let's move on to the surgical suite. I will show you how we do it here in our office. Of course, we all have different equipment and office spaces. I will show you how we stand around the patient, which I think is critical for navigation. And you can, of course, change or adapt this to your practice. And yes, I do love checklists. I love protocols. I love checklists because it keeps everyone in the team aligned with the same needs. This particular checklist I will share with you as well is a page and a half, and it's laminated in our office. And it is laminated so our team can use a dry erase to cross-check everything that should be in the room, and also to cross-check the systems are running. One of the most common things that I will tell you from my first months of using Navident is the system was not plugged to power. That's a problem. So make sure that always is connected, and that is on the checklist. So in preview, this is a panoramic view of one of the rooms from one angle and from the other angle. In the background, we have always a monitor that has progress notes, the patient's treatment plans, any relevant photographs, and even we many times mirror the Navident screen into that computer. On the Mayo stand, we have an implant motor that has the slow spin handpiece with the connected drill tach and the tracer tool with the tracer, both of which I assure that the assistants know to make sure to tight well. When I walk into the room, when I am going to start working with the patient, I will double check that to assure that we have very good stability of those tags. And then we have the calibrator as well. On the one clinical counter from left to right, I have an implant motor with the provisional kits that I use for the customization of healing abutments or, provisionals, the head tracker, and a portable X-ray unit. And this is in detail what I typically will use for customization of my abutments or provisionals. In the other clinical counter, I may have any regenerative materials if are needed, and also a tray that contains the jaw tracker, the dual cure, both adhesive and composite, the pliers, and a curing light. With the disposable jaw trackers, the newer wire is much more flexible than once before. So I many times don't use the orthodontic plier. Many times you can mold it with your own hands. This is the surgical table. We have the pertinent implant surgical kit relevant to the, for the implant that we will place. I use in most of cases the Densa Burr kit for osseodensification to do either ridge expansion or transcrestal sinus augmentations. We will always have mirrors, retractors, contrasters, hot water available so we can take photographs as well. And this is the room now with the patient in the chair. So this is to me the most important part here. And I want to make sure that you consider, where I will be standing. So if the head of the patient is the 12 o'clock position, I will be standing at the 11 o'clock position with my body very relaxed. By the way, I work standing. Many of you work seated, so I don't think it's any different. But the hands and the posture should be the same. So you want to make sure that your hands are around the patient, relaxed, almost like hugging the patient. But if you have them open and relaxed, you assure yourself not to be touching the tracker, the head tracker especially, and also not to interfere with the line of sight of the micron tracker camera. At the 3 o'clock position relative to the patient head will be my assistant. And my assistant is going to have also a posture that is with the hands open towards the patient without obstructing the line of sight of the camera. The way we look at it is like standing on a balcony, and think of the micron tracker camera as the audience. You don't want to give your back to the audience, right? So you want to just speak openly to the audience, and that's what we try to do. That's how we see the micron tracker camera. The cart, we parted at the 5 o'clock position with the extension arm coming at the 6 o'clock position with the computer facing me at the 5 o'clock position, so a diagonal from me. And then to my right is the Mayo stand, and to its right is the surgical table. And you can see here that I also use, in most of cases, not always, but an Helio X camera to do video recording and photography. So yeah, this is just about the room. It is very fluid once you and your assistant become familiar with standing or sitting around the patient. It basically becomes second nature. So lots of practice is what is recommended. So now let's move on to the planning and the surgery through case presentation. So let's actually go through the workflow through that case presentation, where I will be able to demonstrate to you, pretty much all the advancements of Navident and how the team continues creating solutions to all the clinical challenges. I will be able to highlight pretty much the hardware advancements, as well as the Navident 2.2 features, which we'll be reviewing in detail. You will see some of them through the case presentation, and in session 2, we'll be talking in detail on one by one. So in the first case, I like to highlight one of the features of the software, which is the ability to plan an osteotomy in 300, and turn the implant or the osteotomy in 360 degrees. And when is that very useful? It is extremely useful for endodontics, if there are any endodontists in presence, for epicoectomies, for SFOT, also for canine exposures, and for what I use it the most, which is to outline the sinus wall. So when we have very narrow pneumatized sinus cavities adjoined to natural teeth or implants, or maybe the sinus cavity is compartmentalized, the ability to put this virtual osteotomy in any direction is very useful. As you can see on the three-dimensional rendering, I have 5 osteotomies outlining the sinus wall. Now, in this particular case, I had planned for a transcrestal approach because I do have a residual bone height that is conducive for it. I have 5.1 millimeters. However, I wanted to have a secondary plan. As we all know, many times we plan one thing and we end up with another during surgery, given the bone quality or stability. So I did wanted to have both options open. And ultimately, I planned the case through a transcrestal. I did the case to a transcrestal approach. You can see the outline of the sinus cavity and the bone graft that it was placed. So again, in this particular case, highlighting the feature of the ability to rotate the implant in 360 degrees. Second case is that of the placement of a second molar on the lower left quadrant. And why am I showing you this case? Well, this case is very relevant because I'd like to talk to you about 3 things. One is restricted vertical access and how to solve that problem. Second is one of the advancements of the hardware. And then third, one of the advancements of the software. And you'll see how. So let's talk about restricted vertical access. We know that with Navident and with dynamic navigation in general, we have overcome restricted vertical access as we have the ability to locate the tip of our drill in the target and the center long axis of the target view. And we can start in an angle, and as we're gaining vertical access, we can correct the alignment. And that is a great advantage of dynamic navigation over static guides, especially for the second molar region, where the static guide is going to be very bulky, where we have long drills and long sleeves, very limited access. Now, with navigation, I will tell you that in the lower left quadrant, if you're right-handed like me, you still are going to be challenged with the restricted vertical access. And the reason is when we bring the handpiece to the location, we're coming from the right of the patient through the mouth. That means that we still are going to be restricted. So what I do to solve that issue is I hold the handpiece with my left hand, which is my non-dominant hand. I come from the buccal aspect of the lower left quadrant. I locate the tip of my drill on the target, on the center target of the plan. And with my right index finger, I will stabilize the handpiece. And I complete the osteotomies and the implant placement fully navigated that way. So that helps me overcome that challenge when we have it. So let's go over the case so I can show you the other 2 features that I want to highlight. So the patient was referred to us for the replacement of number 18, and he had another set of issues going for him. He has 3 other implants on the mandible that were placed by different clinicians in different countries, by the way. And not topic of this webinar, but I will be happy to share with you the case in completion. So 3 images highlight 2 of the features that I will be talking to you in this case. On the upper right, we see the horizontal projections of the fiducials that belong to the Navi Byte. And I will elaborate on the Navi Byte shortly. On the lower right, we have the ability to load multiple STLs. And that is a great advantage. So you can see here in pink is the virtual plan for the implant placement. In purple is the STL of the opposing arch that help us visualize the ideal occlusion. As we take the CBCTs with the mouth partially open, this allows us to verify the occlusion. So again, what will be the benefits of loading multiple STLs? Well, first, like I'm demonstrating here, we can verify the patient's occlusion. Second, we can load third-party plans in STL format. And that means you can load multiple third-party plans in STL format. That is very beneficial when we're working interdisciplinary with our orthodontist, using the clean check, the STL from the final clean check for the placement of implants. That is also very useful when we're working with laboratories that have, for example, Blue Sky Bio as their main planning software. We can incorporate those plans in STL format. And you will see it for sure in an upcoming case for the full arch planning. So what is a Navibyte? It is a block that has embedded fiducials for registration, and it is called point pair registration, as we're placing the tip of the tracer in each of these fiducials. And as you know, Navident has auditory cues to tell you when we have registered a surface. So when we're doing fiducials, we basically have, we can actually do the point pairing. And I'm sorry, I just lost, it looks like I'm losing some connectivity. I'm hoping that everybody can hear me. Jason, can you hear me?
We can hear you. You're loud.
Yeah. Loud and
Perfect.
clear.
Just a little sound, okay, perfect. Thank you.
Well,
So, okay, fantastic. So again, the ability to do point pair registration through fiducials in a block is very useful, especially when we don't have enough landmarks for registration. And that is for patients who are partially edentulous that either don't have enough teeth or the teeth available are mobile. Now, this is another great solution for, again, the small field of view, for a 4 by 5 centimeter field of view. As long as you're capturing 3 of those fiducials in your field of view, you will be able to register the patient. So the block is stabilized with blue mousse, or with any PVS material, ideally that is radiolucent. And then we put this in the patient's mouth to obtain the CBCT, and then we put it back in the mouth so we can proceed to do the procedure, to do the registration of the patient. So you can see here the jaw tracker that is affixed to the mandible through composite, and the Navibyte that is resting on the patient's mouth as we do the registration. And of course, after you complete the registration, you remove it and you complete the surgical procedure. So we select the landmarks for registration. I am combining 2 of the fiducials from the Navibyte and then 3 natural teeth. So I am combining trace registration with point pair registration. And you can see how the software recognizes the fiducials of the Navibyte. So this is the implant fully navigated. And now I am customizing an abutment to be placed. The tissues are sutured in place. And the implant is now placed. One thing that, again, I omitted one of the slides to demonstrate or to show you what's going on number 19. You can appreciate here there is a remanent root that was left either intentionally or unintentionally as a partial extraction therapy. This case, when I evaluated the patient, there were no peri-implant pathology. There's no bleeding or probing, no exudate. The patient was not even aware that he had a remanent root in there. So I'm doing some research with the dentist who had placed the implant to see if we have any images to follow up. If we see any pathological changes of concern, we will certainly remove the root tip. So 3 weeks post-op, showing the tissue doing really well. And again, I just wanted to highlight in this particular case 3 things: the restricted vertical axis and how to overcome it. Second, I wanted to talk to you about the Navibyte and the ability to do point pair registration through fiducials that are embedded on the block. And then third, the ability to load multiple STLs, in this case, to verify the patient's occlusion. The upcoming case is one that we started before the pandemic started. It's a stage case, and unfortunately, we were supposed to have completed it the first week after, when we returned, which was back in May 18th. However, the patient was one of those who had COVID, so we're waiting on a negative test before we can schedule him again. We're hoping by the beginning of July, we will be able to complete the case. And I'll be very happy to share the completion because it's a very interesting case. So here I will be highlighting 2 things. One is from the hardware, is a bone anchoring tracker. And the second is the ability to load third-party plans, multiple third-party plans in STL format, so we can plan for the virtual full arch navigated implant supported restoration. So what is a bone anchoring tracker? It is a tracker that is affixed to the maxilla or mandible with fixation screws. And when is this beneficial? When do we want to use a bone anchoring tracker? Well, we like to use it when we don't have enough teeth or pretty much supporting structures to affix a composite-based jaw tracker. The other is for full arch cases, as you will see. And last is when optimal stability of the tracker is paramount. And that includes in cases of general anesthesia where we don't want to have any accidental dislodgement of this tracker. So in this case, we had a patient refers to us with a maxillary long expand bridge from number 4 through number 15, which had recurrent decay and it was non-restorable. In the mandible, we have periodontally hopeless number 20, 21, and number 28. So we will obtain the diagnostics. We acquire photographs, extraoral, intraoral photographs, also a video that reflects not only the frontal but the side view of the patient as he is pronouncing the letters M, and to show the lips at rest, the letter F and B, as well as the letter S, and also counting from 55 to 70 as per request of our lab technician, lab partner, Lars Hansen, in order for him to be able to incorporate into DSD so we can locate the incisal edge and the curve of P. We obtained the CBCT as mentioned prior. This is a full arch case, so we need to obtain a large field of view to incorporate anatomical landmarks such as the zygomatic arch, the nasal spine, and the base of the orbit. And for the optical surface scan, once again, remind the team to pace properly to retract so they have a good acquisition of this particular image. So once we collected all the diagnostics, we do this in one visit. We submit to the laboratory all these files in JPEG, MP4, STL, DICOM. And then Lars Hansen will create the dynamic navigation in media prosthesis. We had offered to the patient 2 different options for care. And that includes a bimaxillary implant supported restoration. That is because the patient is class 3 and in an edge-to-edge relationship. The second option is a maxillary full arch implant supported restoration against retention of 22 through 27 and addition of implant supported bridges on the lower left and the lower right. So the patient has been very happy with his function, his smile, and he doesn't want to lose any more teeth if he doesn't need to, so he chose to go with option 2, so retention of 22 through 27. So 2 options for the maxilla. We have an all-on-4 and an all-on-6 solution. At this point, we're going to add fixation screws as fiducials for point pair registration. I have to admit that we probably added way too many. You only need to have maybe 4 to quadrangulate the position of the fiducials so you can have proper registration of the patient's jaw to the CBCT. And we added 1 on each side on the mandible to facilitate triangulation of the registration. So this is the final dynamic navigation in media prosthesis for an all-on-4 solution on the maxilla against the remaining natural teeth 22 through 27. The final plan for the mandible with implant supported bridges on 19 through 21, 28 through 30, with immediate implants on number 21 and number 28. The selection of the landmarks for the mandible, including natural teeth for trace registration and fiducials recognized by the software for point pair registration, again allowing us to have better triangulation of the registration. In this case, I could have certainly done the registration through the trace on the natural teeth. Since we were adding the fiducials on the maxilla, we added 2 on the mandible to again improve the triangulation of those fiducials.
Hey Silvia, just a quick question from Dr. Schell. Did you place the screws through the mucosa?
Not.
No.
No. We actually flapped the area. You could. You certainly could. I find there are different ways. You can do a full thickness flap. You can do individual, specific access, very conservative access through the vestibule, or you can just basically do them through the soft tissue. I prefer to have full control. I want to see exactly where I'm placing them so I know where to remove them, but every clinician can do it differently. I think that there's no right or wrong with that.
Great. Thank you.
Absolutely. Thank you. All right. Let's see. So the placement of the jaw tracker, the bone anchoring tracker, you do a full release, full thickness flap. We use a straight handpiece, a striker to create the pilot holes and a driver to place the fiducials. I'm sorry, not the fiducials, the fixation screws, which can be used as fiducials anyways. And this photograph just demonstrates how the bone anchoring tracker is bended down, clear from the clinician's way, and very rigid. And again, this is important, very important. The optimal stability of this tracker is paramount, especially in cases like this where the patient is under IV sedation or general anesthesia. And that prevents, again, the accidental dislodgement of the tracker. So the osteotomies are being navigated, and the implants are being navigated in place. All 4 implants placed. Bilateral bone grafting was done simultaneously with the placement of the implants. And now let's move on to the maxilla, which is very exciting because here I can show you how we can merge multiple or register multiple STLs, basically third-party plans in STL format. You can appreciate, and I actually like to color them to differentiate them, and you can do that with the software, by the way. Instead of all being pink, you can make them any color you want. So I designated in blue the Virtual Anatomical Bone Reduction Reference Guide. That is the STL, the anatomical STL, that is giving me the reference point so I can create the osteotomies to do the bone reduction. In yellow, the jaw, the saw cuts basically are really osteotomies that are 10 millimeters apart, that once we create the outline or once we create the markings, we can create the bone reduction with a piezo or a saw. And then in pink is the prosthesis. And then in yellow, the yellow projections are the implants, which also, by the way, were imported from Blue Sky Bio into Navident with the final position restoratively driven based on the prosthesis. So this is showing the projections where the bone reduction will be done based on that bone reduction reference guide. And without the DICOM, I just wanted to show you the the STLs. So you can see the location and the distribution of the implants. In the area of number 4 and 13, we're placing implants in tilted, since this is an all-on-4 solution. And on 7 and 10, they're axially planned. This is the final plan for the maxilla. On the panoramic view, you can see the location and distribution of the implants in yellow. You can change the color of the implants, by the way, as well, which we will see in later cases. In purple, you have the prosthetic pins. The prosthetic pins were added by, again, our lab partner, Lars Hansen, in order to stabilize the prosthesis and assure proper alignment of the provisional. And they will be removed, of course, once the conversion is done. Now, I draw back from the prosthetic pins on the posterior region. You can see here that those prosthetic pins are in alignment with a couple of the extraction sites. And of course, they will not be very stable. So the midline will be perfectly fine. The posterior ones, not so much. And therefore, for the prosthesis or the provisional, you can add winglets or have the laboratory and add winglets or a palatal extension to stabilize the prosthesis, which can then again be removed after the conversion is done. On the axial view, you can see the projections of the bone reduction that is planned at 10 millimeters apart. And all 4 implants are planned. So what I did, and you can see that there is superimposition of the third-party STL from the implants. And that is, you can see the implants in the background, and superimposed, you have the implants from Navident that I superimposed into the plan. So I can navigate the case based on the restorative plan. The selection of the landmarks, I am combining natural teeth and fiducials that are recognized by the software. Now, the reason I am doing this is twofold. One, as you can see, this patient has a lot of restorative work, and we will talk about this particular issue in session 2. But for today, I just leave you with this. You can definitely do trace registration on restorations. You have to explore the restoration a little bit. However, in this case, we added the trace registration to the fiducials because I need to remove these teeth. And once we do the extractions and the bone reduction, if for any given reason we were to lose any accuracy during the navigation, I need to have a fallback plan, and those will be those fiducials that we have there. So we can use those fiducials to do point pair registration during the surgery if we need to do registration of the patient once again. So again, in this case, I wanted to highlight two things. One is advancement of the hardware, which is the bone anchoring tracker, which is very important for the full arch cases, and as well for any case where you have not enough teeth where you can affix a tracker, or where the optimal stability of the tracker is imperative. And also I wanted to highlight the ability to load multiple plans in STL format. In this case, we added 3 STLs to this plan to be able to plan the virtual full arch navigated implant supported restoration. So I think for today, we have covered a couple of things at large. One is the navigation workflow in our office. We went through the diagnostics, the communication with the lab, also the surgical suite, and in part with the planning and some of the surgery with some of the cases. I have highlighted some of the features of Navident 2.2, including the ability to orient the osteotomy or implant in 360 degrees. Also the ability to load multiple STLs and multiple third-party plans in STL format, and the different forms of registration, which are trace registration and point pairs. Next week, I will cover the remainder of the features, and of course, we'll be going over cases, challenges and solutions, advancements of the technology, and emerging applications. I think that this is a good time to open the pretty much webinar for questions. If there are any, I'll be happy to share any tips and tricks. I'd like to make it more of a dialogue if we can. That would be great.
One thing I'd like to point out, Silvia, thank you very much. That was very comprehensive. One thing you also added in the last case that you didn't really talk about, I think you'll be talking about it next week, which is the planning of the saw cut, correct? I mean, when you were doing the bone leveling and you were showing all the all the 10 millimeters apart, those were basically a saw cutting, which is a feature you're going to talk more about next week, correct?
And we can talk about it today if you like. I think this case is particularly one that demonstrates that. So we can go back into that case if you want me to do that. That's perfectly
well,
fine.
you're doing the bone leveling, basically utilizing Navident's plane cutting for that.
Yes. So basically, I have with the planning, I have added those saw cuts, and you can distribute them as 10 millimeters apart or more or less. You can customize that. And my goal is to think of doing an osteotomy horizontal, that I'm going to go through those cuts, which can be done also with an osteotomy of an implant. And then I will connect those dots all together with a saw, either the piezo or a regular saw, correct.
Right. And then also, obviously, you're working with Lars very closely, Lars Hansen.
Correct.
There's a lot of comprehensive work back and forth when you're doing complex cases like this. And I just wanted to make sure that everyone's aware, we will provide a version of the planning software to your laboratory. We'll do online training with them to make sure that they know how to use it very, very well. And then they'll be able to work with you the way that Lars and Silvia work together. Quick question I see here, is the new version of the software automatic, or do I need to download? Dr. Yu, as soon as you're connected to the internet, it should happen automatically for you. So once you connect your Navident system to the internet, that should get updated. Takes literally a minute, and then you should have all of these updates. For the guidance of the sinus lift window, are we only able to mark individual osteotomies, or is there a feature to fully outline the window? Currently, it's only individual osteotomies, and as Silvia, I asked her this question last week, she finds that that's much more important than outlining the entire window, right?
Correct. And it is very critical because at that point we're working in a sense hybrid. We are creating the markings for the sinus wall, and then I go directly with and we all do the access differently, okay? So I particularly like to use a high-speed handpiece, so I connect all those dots and I create the outline. And again, it creates a very for one conservative outline and wall, because there are really no estimations. You're basically going straight where you need to be. And also you're being very protective of the adjunct structures and avoiding septums and avoiding, again, compartmentalized sinus cavities. And I finished the axis as I'm getting close to the sinus cavity and I have visualization, with the change of color, I will then change to a piezo and then finish with hand instrumentation.
Okay, great. Does that answer your question? How many osteotomy markings are you typically using? 5?
In that case, yeah, 5. And it depends because every sinus cavity has different configurations. Some of them are very round. I particularly find it very helpful for the narrow pneumatized sinuses that look like an inverted pear, or, again, when you have a septum. So, it depends. Sometimes I do more. It depends on the configuration of the sinus cavity and the available anatomy.
Okay. Dr. Schell's he loves the septum idea.
Yes,
Can you read? You can't. You're not reading these. So if Silvia doesn't respond to you directly, guys, I'm sorry, I'm the translator. It's simply because she's not reading these because she's sharing her screen. So I'm reading for her. Yeah. Excellent. Dr. Schell's 12 cases in, but he says he's loving it.
Fantastic. Good. Fantastic. One of the things, again, and I have to highlight this over and over for all of us, and this is true for any technique, for any technology, it is definitely doing these cases and not allowing your team to tell you, oh, are we going to do this navigated, or you want to do it freehand, or is it a study guide? No, in my team, all cases are navigated. There's no going around that. It's the only way you will become familiar faster, and your team as well. It's like driving a car. It's like doing anything. The more you use it, the better you will understand it. So good for you if you're using it, in all your cases.
Yeah, I know we have a very wide variety of people here. We have people who've been using it for years. We have people who've been using it for a few months. And then we also have people who probably are slightly confused by this because they haven't received their system, or they just received it and they haven't had their training yet. So we're open to any and all questions for the next few minutes here for sure. But also we will do continued online training with you, and if possible, which we can do this, we have people in the United States, Canada, Europe, and Asia who are all willing and able to travel within their particular areas. So by all means, start scheduling with Beth your personal one-on-one training so we can get you up and running as soon as possible, or additional training. Hi, Beth.
Hey, thank you, Silvia. That was
Absolutely.
amazing.
No more questions for me, eh?
Well, so if there's no more questions, I want to let you all know that this evening, and probably right now, you'll be receiving the link to part 2 of this series, which will happen next Monday, same time. So look for that. And then tomorrow, you'll be receiving the link from me and Navident that will include the recording of this session, as well as the documents that Silvia has so graciously agreed to share. And again, the link. If you have any questions or you'd like to set up training, please don't hesitate to let me know.
Yeah. So next week we'll be doing, Silvia will be presenting a couple of more cases, and then we'll be going into detail in some of the other parts and pieces. We'll also, she did speak about a few hardware pieces today, about the Byte and the Tracker B, as we call it, or bone anchored tracker. We'll also be expanding on those and explaining them in a bit more detail and introducing a couple of more to you next week as well. So by all means, please come back, and thank you very much for your time thus far. When are those going to be available? I knew that was coming. It's a very good question. They are, all of those, we're trying to, a couple of them are ready now to be sent out, but we do know that over the years we come up with a lot of advancements, and we come up with them fairly quickly, and they kind of trickle out little by little. So what we'd like to do is we'd like to take these 5 new hardware pieces that we have coming out, get them all ready in production, and send them all off together as a package. So what that means is it's probably going to be and this is conservative, 2 to 3 months. So I'm trying to promise and over-deliver here. So 2 to 3 months that we'll have those out. So before September, hopefully in August sometime for wide extended use.
Perfect.
Okay.
Okay.
Thank you everyone for the attendance. Thank you, Jason. Thank you, Beth, for organizing this event. And I am happy to go over any tips or tricks or anything, really. I mean, the idea is to make this educational for everyone. It's, you know, in these particular formats, it's a great solution based on the challenges we have. However, it's always great to be in front of people to show them hand in hand. So please feel free to contact any of us, and I'll be happy to help with any tips and tricks myself from the clinical perspective.
Excellent.
Yeah, that's great, Silvia. Thank you so much. And thank you all for attending. And I look forward to seeing you all next week. So be well. Good night.
Be well. Thank you. Take care.
Good night.